everyone. Today's journal for discussion is on a topic of ARDS called as use of airway pressure release ventilation in patients with acute respiratory failure due to COVID-19, results of a single center randomized controlled trial. This was done by Miguel et al., published in Critical Care Medicine in April 2022. Coming to the background of the trial, mortality of acute respiratory distress syndrome is very high at around 40%. An ideal strategy to manage mechanical ventilation in COVID-19 ARDS is still not known. If you see the data with respect to non-COVID ARDS, there was one trial in 2017, which was an RCT, where they have seen the application of APRV versus conventional low tidal volume ventilation, and this showed some benefit. The basis behind proceeding with this trial was that APRV allows for spontaneous ventilation with much lesser sedation requirements, and this may improve outcome in patients with COVID-19 ARDS. So what is the evidence until now? Until now, the only and largest randomized clinical trial, which compared APRV versus low tidal volume ventilation, it had a number of patients to be around 63, and it included only trauma patients. And the pitfall of this trial was that it was underpowered to find significant differences in relevant outcomes when it compared APRV versus low tidal volume ventilation. So the clinical question which the authors asked was, in ICU patients with early COVID-19 ARDS, does airway pressure release ventilation, that is APRV, compared to conventional low tidal volume ventilation, improve ventilator-free days at 28 days? The endpoint which they looked at was the ventilator-free days at 28 days, which is a good endpoint to look at because mortality is a much harder endpoint in compared to ventilator-free days, which is a much softer endpoint. So in terms of the endpoint, this was a good trial. So the PICO statement with respect to this trial was, the population was adult patients with early COVID-19 ARDS. The intervention group was managed with airway pressure release ventilation. The control group managed with conventional low tidal volume ventilation. And the outcome which the authors looked at was the number of ventilator-free days at 28 days. The inclusion criteria was patients who were having acute respiratory distress syndrome according to the Berlin definition of ARDS with PF ratios less than 300, and they had to be less than 48 hours of endotracheal mechanical ventilation. There were several exclusion criteria. Amongst a few important ones were pregnancy. The patients were less than 18 years old. If they had a pre-existing condition with a mortality which was exceeding more than 50%, if they had confirmed intracranial hypertension, which is one of the causes, which is one of the reasons which would not have allowed the authors to proceed with prone ventilation. If the patients had they do not resuscitate order, so such sort of patients were included in the exclusion criteria. The design of the study was a single center study in Mexico. This was a tertiary care referral center. Patients were recruited between March 2020 and November 2020. They were randomized to either APRV or low tidal volume ventilation within 48 hours of endotracheal intubation. Informed consent was taken from the relatives of the patient. The method of randomization was based on a permuted block randomization with a block size of 4. Assignment numbers for the blocks was generated by the computer randomly. And if you see, the trial was blinded only to investigators and data analysts. The clinicians, obviously, who are performing the particular mode of ventilation could not be blinded. Elaborating more on the study design of the trial, this trial was basically performed in a single center in Mexico. This center actually had an ongoing RCT which was comparing APRV versus low tidal volume ventilation. However, in the midst of this ongoing RCT, the COVID-19 pandemic came. So a non-pre-specified interim analysis was performed to modify this protocol of the ongoing RCT to include COVID-19 patients. Post-randomization, all these patients received a 12-hour stabilization period of protective low tidal ventilation according to the ARDS protocol. This 12-hour stabilization period was same for both APRV and low tidal volume ventilation in the initial 12-hour period. To understand more about the trial, we first need to know what exactly is an APRV mode of ventilation. If you see, APRV mode of ventilation is amongst the newer modes of ventilation, where the patient's inspiratory and expiratory pressures and time are different from the conventional modes of ventilation. If you see this graphic here, this shows three scalars, that is the pressure time scalar, the flow time scalar, and the volume time scalar. The pressure time scalar over here, the flow time scalar, and the volume time scalar. If you see the inspiratory phase in the pressure time scalar, there is a sudden steep rise in the pressure. This is called as the P high, and which is sustained for a certain amount of time, approximately around 5 seconds. This is called as the T high. Then there is a drop in the pressure, which signifies the expiratory phase, and this is signified with the T low, which is usually zero, set at 0, and this T low is set for a certain amount of time called as T low. This is the expiratory phase time, that is T low, which is approximately 1/10 of the T high usually. Similarly, the flow time scalar denotes the flows which happen during the inspiratory and expiratory phase. If you notice here, in the inspiratory phase, there is a rise in the flow, followed by the flow becoming almost zero for most of the inspiratory phase. And in the expiratory phase, there is a peak flow which happens here, followed by the drop in the peak flow to around 75% of the peak expiratory flow. There is a drop up to here, and then the machine cycles off to the inspiratory phase again. Similarly, in the volume time scalar, if you see here, there is a certain amount of volume which is generated in the inspiratory phase, and in between there are certain spikes here, which is denoted over here. These are the spontaneous breaths that the patient has been allowed to take, which occur over and above the amount of tidal volume that is generated in the inspiratory phase. So if you see here, the settings which are done in the APRV mode of ventilation are the amount of FiO2, the slope of the inspiratory phase, that is 0.2, that is the amount of time that it takes to achieve the peak pressures in that is the P high. This is the slope of the inspiratory phase. Then there is a P high, which I just explained. Then there is a P low, there is a T high, and there is a T low. So these are the settings that happen in an APRV mode of ventilation. A key feature of APRV mode of ventilation is basically to see that the expiratory, if you focus on the expiratory phase over here, there is a peak expiratory flow which happens in the expiratory phase, and there is a cycling from the expiration to the inspiration at around 75% of the peak expiratory flow. This is an important concept with APRV mode of ventilation, and a key concept because the amount of time that the mode allows you in the expiratory phase, that is the T low, is extremely important because if you allow too much of time in the expiratory phase, and if you allow the peak expiratory flow to fall to more than 75%, if you allow the expiratory flow to fall more than 75% of the peak expiratory flow, then you might lose the amount of PEEP that is generated in the lung and the amount of recruitment that has happened in the lung. So it is very important to keep the amount of expiratory flow at around 75% of the peak expiratory flow, and then cycle off to inspiration. So now coming to the details about the intervention group, that is the APRV group. The initial settings on APRV were as follows. The P high, or the high pressure, was set at the same plateau pressure measured on an inspiratory pause of 0.5 seconds in the previous volume controlled mode of ventilation, with a maximum allowed level of around 30 centimeters of water. The low pressure was set at 0 centimeters of water. The inspiratory time or the T high was initiated around 4 seconds, and the expiratory time or the T low was set at around 1/10 of the inspiratory time, that is 0.4 seconds. But based on the analysis of the flow time curve at expiration, it was adjusted. The expiratory flow termination, which I just mentioned in the previous slide, was maintained between 50 and 75% of the peak flow. But as the authors have said, the preference was towards 75%, the expiratory flow termination to be set at 75% of the peak expiratory flow. The control group, that is the low tidal volume ventilation, was continued. Low tidal volume ventilation group was continued on ARDS network protocols, where the tidal volume of 6 ml per kg of predicted body weight was set. This tidal volume could vary between 4 to 8 ml per kg predicted body weight. The lower limit of 4 ml per kg body weight in case the plateau pressures were went greater than 30 centimeters of water. The upper limit of 8 ml per kg predicted body weight if needed to manage patient ventilator interactions or acidosis. So the common therapy to both the groups, that is APRV and LTV groups, were other supportive therapies such as analgesia, sedation, neuromuscular blocking, prone positioning, and mechanical ventilation weaning. The endpoints of this trial was the primary endpoint, which was ventilator-free days at 28 days, and several secondary endpoints, most important being the rate of severe hypercapnia, which was defined as an elevation of PCO2 at greater than equal to 55, along with a pH of less than 7.15. The number of recruitment maneuvers that were required, the barotrauma, number of episodes of barotrauma, the tracheostomy rate, the length of ICU stay, and the all-cause hospital mortality. The statistical analysis was done based on a sample size of 130 patients, that is 65 in each group. The authors arrived at this number by the fact that the amount of decrease in the ventilator-free days was by 4 days with a power of 80% with a two-sided type 1 alpha error of 0.05. This number of reduction of 4 days was based on a previous trial which compared APRV versus low tidal volume ventilation and found around a difference of around 4 days between the two groups. The categorical variables represented as numbers of percentage, and the continuous variables represented as mean or median for normal or non-normal distributions respectively. The categorical variables were analyzed using chi-square test or the Fisher's exact test for comparison between the groups. Similarly, the student's t-test, Mann-Whitney U test for comparison between the groups for normal or non-normal distribution respectively. The results of the trial showed that there were around 142 patients who were assessed for eligibility, and out of which 101 underwent randomization, out of which 51 were in the APRV group and 50 were assigned to the low tidal volume ventilation group. In the APRV group, 3 patients died within 48 hours, 2 were extubated within 48 hours, and 1 was lost to follow-up. And finally, 45 were included in the analysis. In the low tidal volume ventilation group, similarly, 3 died within 48 hours and 2 were extubated within 48 hours. And finally, 45 were included in the analysis. The baseline characteristics of the group on comparing APRV and low tidal volume ventilation showed that both the groups were almost similar in terms of most of the demographic characteristics and their basic ventilation parameters: age, the sex, the amount of AKI, the vasopressor requirements, and the ventilation parameters such as plateau pressures, driving pressures, static compliance was almost similar in both the groups. So both the groups were adequately matched in terms of the baseline characteristics. So the comparison of outcomes between the group showed that the primary outcome, that is the ventilator-free days at 28 days, was actually 3.7 in the APRV group and 5.2 in the low tidal volume ventilation group. So the number of ventilator-free days at 28 days was lesser in the APRV group and more in the low tidal volume ventilation group, but this difference was non-significant. Similarly, out of the secondary outcomes, the severe hypercapnia was the total number of episodes of severe hypercapnia are almost 29% in the overall inclusion of APRV and low tidal volume ventilation. But in the APRV group per se, it was 42%, with low tidal volume ventilation having 15% episodes of severe hypercapnia. This was significant. So the severe hypercapnia was significantly higher in APRV group. The death at 28 days was mostly due to refractory hypoxemia, was mostly due to refractory septic shock, which constituted 84% of the total deaths, and the refractory hypoxemia constituted only about 16% of the total deaths. Also, if you see in the refractory hypoxemia, the APRV group had a much higher percentage of refractory hypoxemia, although this was non-significant. If you see the trends of the various ventilation and oxygenation parameters in the two groups on days 0, 1, 3, 5, and 7, if you compare the PF ratio between the two groups after day 1, there is a big difference between the APRV and the low tidal volume ventilation group. The APRV group obviously has a higher PF ratio. Similarly, if you see the static compliance, the APRV group has a much better static compliance after day 3. If you compare mean airway pressures in between the two groups, the APRV group also has a better mean airway pressure. But if you see the tidal volume being generated between the APRV and the LTV group, there is a much higher tidal volume which is being generated in the APRV group, and the red line which shows the APRV group also shows that sometimes the tidal volume on day 5 and 7 has crossed almost 8 to 9 ml per kg body weight, which is much higher than what is recommended for ventilating ARDS patients. So what were the strengths of this trial? First, it had very low dropouts and crossovers, no dropouts at all, and only 5 crossovers. This is the first evidence of use of alternate modes of ventilation in COVID-19 ARDS, and especially considering that APRV had good theoretical basis, but no much evidence earlier. Moving forward to the limitations of the trial, protocol adherence in APRV group was actually very questionable. There was a lot of heterogeneity in implementation of the APRV protocol. For example, when there was hypercapnia, the protocol dictated that the clinicians decrease the T high, but most clinicians actually increase the T low to allow for more expiration and thus reduction of hypercapnia. Similarly, the implementation of spontaneous breaths was done when the P high dropped to less than 24 centimeters of water as per the protocol. But this was also a lot of, but for this also there was a lot of heterogeneity in the implementation by the clinicians. Early stoppage of trial recruitment was one of the other limitations, and the planned sample size, which was 130, was final at around 90. So there was much lower number of subjects which are recruited in the trial. So to summarize the PICO statement, adult patients with early COVID-19 ARDS was the target population. The number of patients recruited were around 90. The intervention group was managed with airway pressure release ventilation. The control group was managed with conventional low tidal volume ventilation. And the outcome, which was their primary outcome, there was no improvement in the ventilator-free days at 28 days. In conclusion, the authors have concluded that APRV, when compared to low tidal volume ventilation, was not associated with more ventilator-free days or improvement in other relevant outcomes in patients with severe COVID-19. Therefore, their data at this point does not support its use as part of routine care in patients with severe COVID-19 ARDS. So in our ICUs, what is the current situation? We are aware that APRV is still not available in our ICUs. And we are also aware that we still struggle with adherence to ARDS net protocols. And at this point of time, the right cocktail for mechanical ventilation for COVID-19 ARDS has still not been deciphered. So at this point, the best way forward for COVID-19 ARDS is to stick to ARDS net protocols. Thank you.